he has
Got
me
the
wearing
chair
a lapel mic now. It's hysterical. All right, so I'm Marnie. I'm with Respiratory. I'm the staff therapist today, and I have Tim Robbins. He's 85 years old. He has chronic obstructive pulmonary disease. He has albuterol 2.5 milligrams ordered. It's actually not 2.5. It's 80. The liquid is 2.5 milligrams. But I've got albuterol via MDI with a spacer every 4 hours and as needed. I've also got Atrovent 0.5 milligrams liquid via small volume nebulizer every 6 hours. Atrovent also lasts longer than albuterol, by the way. And I have Advair 250/50. So he's gonna get a maintenance medicine twice a day. Okay, all right. Somebody just say hello for me.
Hello.
Hi, I'm Marnie, I'm with Respiratory. How you doing?
Doing good.
Doing all right? I'm here to give you your breathing treatments, is that okay?
Yes.
Okay, before I get started, let me get your name and date of birth.
Kareem Warren, May 17, 1974.
Okay, well you are who you say you are. Wonderful. How are you feeling today?
Oh, okay. That could be better.
Okay. How's your breathing feel? Yeah?
Sort of, bro.
Okay, I'm gonna help you with that, okay? The whole time I'm doing this, I'm looking at him, all right? I'm looking at him, I'm looking for any accessory muscle use, I'm checking out his color. I'm just generally getting an idea from my perspective on how well he's doing. So the whole time I'm looking at him, right? I'm also asking him his perspective, okay? How do you feel, right? Because then I could go, well, from my view and from his view, we can kind of meet in the middle somewhere maybe. Okay. I'm also looking, is he on any oxygen devices? He's not, he's on room air, okay? So what I'm gonna do is I'm gonna give you albuterol with a spacer. Have you ever taken that before?
Once or twice.
Once or twice? Okay.
Long time
So that's
ago.
gonna open up your lungs, make it easier for you to breathe. I'm also gonna give you Atrovent with a nebulizer. You ever used a nebulizer before?
Yes.
Okay. We're gonna go back over that too. That also opens up your lungs. And I'm also gonna give you something called Advair. Have you ever taken Advair before?
I have.
Okay. That contains a steroid to decrease inflammation, and then the other one opens up your lungs as well. It's a longer acting guy, okay?
Good.
Okay. All right, I'm gonna go ahead and get started. So first thing I'm gonna do is get some vitals on you. So I'm gonna pretend that I have this with me. All right. So I'm gonna stick this little guy in your finger. Everything likes to hang out with me. Your finger, turn it on. And then you would ask me, well, what's my oxygen saturation? Because you don't have any actual number, and I'm gonna tell you it's maybe 96. Is that normal?
Mm-hmm.
Yeah. Anything above 92, we're doing pretty good, okay? And then I'm gonna check my heart rate. What's my heart rate?
90.
90, what's normal?
60 to 100.
Okay. Then I'm gonna check my respiratory rate without telling the patient, right? What's my respiratory rate?
12 to 20.
12 to 20, what's his?
12.
12, so is he doing okay? Does that tell me just from my assessment, my heart rate's in normal range, my respiratory rate's in normal range, my oxygen's in normal range. He's doing pretty good right now. Now I gotta listen to him, right? Okay. All right. Listen, yada, yada. Sit him up, listen to his
So
back.
if you're coming to give the treatment, then shouldn't those things be off? They shouldn't be
What?
normal, right? Like heart rate.
Well, they should be.
Right.
But what if he came in for big toe surgery, right? That's the thing. He didn't. So it's just kind of, he's here with an exacerbation. They should be abnormal, we would think. But maybe he's doing okay right now. He gets up and goes to the bathroom. He's not okay after that. He calls you up. I can't breathe. All right, so we're listening. What would I expect his lung sounds to be if he has COPD? I'm gonna tell you. Diminished. You want to hear decreased air movement. You're not going to hear good airflow. The other thing you might hear with them is wheezing, okay, which is kind of like that. Oh, it's a mosquito. They've been loving me lately. Right, so you'll hear wheezing, decreased lung sounds. It just won't sound like there's a lot of airflow in there. Okay, so he has that. He's diminished and he has an expiratory wheeze. Okay. All right, so I get an assessment. How have you been coughing?
Yeah.
You been coughing anything up? What color is it?
Clears, white.
White.
Not yellow.
White. I would get with COPD. How about yellow? Because he's got an infection. We'll give him an infection.
A little yellow.
Okay, so it's yellow. How much? Dime, nickel, quarter, half dollar?
Maybe a dime.
Dime, so it's a scan amount, right? A little bit. Is it thick, thin, easy to cough up?
In the middle.
So it's in the middle. So with these guys, I would expect thick, kind of thick, tenacious kind of stuff. Okay. Does it taste bad?
Can't taste.
Can't
I
taste?
don't know.
Okay. See, on your thing is, does it smell bad? I'm not smelling it. Does it taste bad? It smells bad. Okay. All right, so we're gonna get started. So the first thing I'm gonna do is give you some albuterol. Is that okay?
Yeah, sure.
Have you ever used a meter dose inhaler before? Okay. Well, I'm gonna go over it with you anyways. Is that okay?
Sure.
Okay. So the first time you ever get it, you wanna shake it. And that's to mix the medicine together. The first thing you wanna do again is prime it. Okay. Then you're gonna stick it in the back of this guy. And what this guy is designed to do is hold the medicine so that you get the most medicine possible, okay? It also helps it from kind of getting in the back of your throat and giving you some of those symptoms that you might get, which is jitters and things like that. We'll pretend this is his bedside table. So what I want you to do is I want you to blow all of your air out. I'm gonna tap this guy and you're gonna take a slow, deep breath in, okay? You're not gonna go real fast because it'll make it whistle, and if it whistles, that means that you pulled too hard and too fast and you probably it went into the back of your throat, not so much into your lungs, okay? Okay, so you ready? Blow all your air out. You're gonna hold your breath for 5 to 10 seconds. Why am I holding my breath?
Keep the medicine inside.
You wanna maximize deposition. If I inhale and then I just blow right back out, I'm gonna blow some of that medicine back out. You wanna hold it there and allow those particles to deposit on the airways, okay? So that's why we do that. So you've got 2 puffs ordered, so we're gonna wait 1 minute in between. Okay. Ideally, it's 5 minutes. We don't have that kind of time. 1 minute. So it's been 1 minute, we're gonna do it again. You ready? Blow all your air out. Slow, deep breath. Again, hold for 5 to 10 seconds. Excellent, good. Any questions? Next medicine I'm going to give you is called Atrovent, and that's also going to open up your lungs. Have you ever done a small volume nebulizer before?
I have.
Okay. You okay with the mouthpiece?
Sure.
All right, since I don't have any monitors at work. All right, so I'm going to take my medicine out, and I'm going to put it in my nebulizer. Sorry. You can do it this way. You can take this off and squirt it in here. There's no wrong way to do this, okay? And then we're gonna pitch that too. All right, so I'm gonna turn this between how much flow?
6 to 8.
6 to 8. And how do I know?
Pressure.
So what you're looking for is that good mist, okay? See how that's fine? Nice fine mist coming out. I like 8 liters personally. See, that's got better flow. And so you don't want it to, you wanna make sure that it's got a good fine mist. So what you're gonna do now is you're gonna put this in your mouth. I want you to breathe in and out. Every once in a while, I want you to take a deep breath in. I want you to hold your breath, okay? And that's just gonna help that medicine get deeper into your lungs and be more effective. Okay, make a nice deep breath in and hold. Good job. Make sure that you gotta watch patients because they'll breathe in through their nose and this will just be doing this. You wanna see that disappear with each breath, okay? If it's not disappearing with each breath, they're not taking a deep enough breath. So you gotta keep an eye on them, right? You gotta keep an eye on them. Okay, so it's sputtering. When it sputters, you know it's about done. If you got a COPD patient, they're gonna flick it. They're gonna want every drop of that. Okay, so it's sputtering now. We're gonna pretend it's sputtering. We're gonna turn it off. Okay.
It would normally take longer though, right?
Oh yeah.
Okay.
But for your, and then this will come out, okay? I'm gonna dump out any excess that's in there, and I'm gonna rinse it with some sterile water, and that's basically what I just did. Pretend that was what I just did. And then I'm gonna take it and put it in the patient's bag, and I'm gonna hang it behind there. Okay. Pull this to the side. How we doing?
Good.
Keep your wrappers. Okay, keep your wrappers. I'm gonna put this over here. The next thing I got for you is Advair. Have you ever taken this before?
I have.
Okay. All right, so then you know to open it, you're gonna do this. You're gonna flick this little switch here. You're gonna hold it like a hamburger. There's no vents on this guy, so you don't have to worry about them covering the vents with their fingers. You're gonna blow all your air out away from the device. What happens if I blow into it?
Powder will come out.
No, you get it wet and it'll start.
Yeah, so this is a powder. So if I blow into it, all that moisture can actually clog it, and then they don't get the medicine. So you wanna blow, you always wanna tell them exhale away from the device. Then you're gonna put it in your mouth and you're gonna go, this one's a rapid deep breath in for the dry powder. That's how you get it in there, okay? So you good?
Good.
Okay, you ready? Blow all your air out. Okay, big deep breath in. Good job. And this is just twice a day for you. I'm gonna also have you rinse your mouth because you had a steroid in there. Why do we have them rinse? Swish and spit.
Rush.
Rush. So steroids can decrease your immune system, right? And if particularly in my mouth, I get a sore tongue a lot from my steroid. I'm like, I guess I didn't rinse well enough, right? But you could get a yeast infection in your mouth. It's rare, but for some reason, fluticasone seems to be the guy that likes to give patients thrush. Have you ever got a sore tongue from your Advair? It's like kind of, mine was just the tip of my tongue for some reason. I always seem to get a little bit of pain. But you can get, and then they have to take something called magic mouthwash to get rid of it. So I swish and spit after your meds because they taste bad. So we swished and spit. Now go ahead and take a deep breath in and cough for me. Okay, that was kind of weak. Let's try that again. Good. And can I learn a lot from that cough? So what do you hear with him again? I hear bronchitis, right? Did you hear him cough anything up?
No.
No, so I can, if a patient coughs up and swallows it, I know whether they coughed up a loogie or not, right? Okay, I can hear it. You can hear it sounds big, it sounds small, it's dry, it's chronic, like wheezy sound when they cough. You learn a lot from a cough. That's the number one thing students forget to do is ask their patient to cough. Okay, it tells you a lot. So you took a deep breath and a cough. Did you cough anything up?
Not this time. Yes.
Yes. How much did you cough up? A dime, nickel, or a quarter size, $half size?
Dime.
Dime. Okay.
Yellow.
So small amount, right? Any bad taste?
It didn't taste good.
Doesn't taste good. Okay, so that's also a sign of infection. And we got amount, we got color, consistency. Is it thick, thin? Feel like it's hard to cough up?
In the middle.
Kind of in the middle.
Thickish.
All right. So if it's okay with you, I'm going to check your vitals again. Is that okay? So again, what's my oxygen saturation?
9. You want to be over 92? 90.
Right. So I just gave him a nebulizer on 100% oxygen at 8 liters. So would I expect it to be higher now?
Yeah.
Mm-hmm. And oftentimes you're going to see that. So you got to be careful because you'll want to titrate their oxygen down if they're on it. The reality is the only reason it's higher right now is because you just gave them a nebulizer with 8 liters of flow. Okay? So you will notice that their oxygen is higher. You come back 15 minutes later, it'll be back to baseline. Okay, so just don't ever, you'll notice that correlation. Unless you give it on room air.
Would you listen to their lungs in between each application or at the total end?
I would just
Beginning
do it
and
again.
the
Yeah,
end?
because the albuterol takes 3 to 5 minutes to kick in anyways, right? So and it's gonna peak in about 45 minutes. So if it takes you 15, 20 minutes to do a treatment, that's when you're gonna really hear maximum, right? You're gonna hear more dilation then. There's no point in really doing it in between. It just takes up more of your time, right? So I got what's his heart rate? It was 90 before.
So probably like 110.
Okay, so did he have an increase in heart rate?
Yeah.
Because of what do you think caused that?
The albuterol.
The albuterol, and I gave him not 1, but 2 doses of it, right? So there's increased risk for side effects when you have that. So I gave him that. So would I naturally expect a heart rate to increase? Yeah. If it increases by more than 20%, you want to report that. Now, what if their heart rate's already like 120 at baseline?
That's like another problem.
They were probably.
That's another problem. So then you have to go, well, do I want to give this albuterol? If he's sitting there looking like you and me and his heart rate's 120, I might not want to give that. But if his heart rate's 120 because he can't breathe, his heart rate might actually come down after I give him the breathing treatment because he can breathe now. Okay, so you got to look at the patient. You have to understand, because it's also contraindicated to give it for high heart rate if the patient has a high heart rate. But if the high heart rate is because they can't breathe, and then you make them, so you can see how things can actually, fight or flight can actually relax, if we make it so that they can actually breathe. So his heart rate went up. If it didn't go up by more than 20%, we don't have to report it, okay? So we have our heart rate, we have our SAT, and of course I wanna make sure I feel, right? What about my respiratory rate? What's my rate?
Probably 12 still.
Still, it's still 12, okay, so no change there. Color,
Well perfused.
pink, low perfused pink. Okay.
What do you mean by color?
Color, so is he pale? Is he blue? Blue's a sign that he's doesn't have enough oxygen. If they're pale, is he diaphoretic, right? Like they look for other things too, but color's important. Not like color like, right, like between us, but the color of whether he's getting enough oxygen or not.
So are we gonna, in African American patients, are you gonna be able to see color?
I can see your lips, and I can tell that your lips are pink. And if your lips were blue, yeah, so in you, I would look at your hands. So if I have darker pigmented skin, this is gonna give it away. Your nail beds will still give it away. Pull your tongue down, or your lip down. See how pink it is? That's gonna give it away, see?
Alright, bubblegum.
Yeah.
Would we elevate, like sit the patient up a
Yes.
little bit more?
Yeah,
Before
so-
we give all the milk?
Yeah, so he's actually in a decent position because he's a kid, and this is actually, he's in an okay position. So you want it, probably about
45.
semi-foul, yeah, 45, semi-fowler. This bed's, we gotta plug it back in. But he's actually in a decent position. If he's laying flat, which we might lay him flat for your, right, test, how, is it, your nebulizer gonna work, right?
No.
Laying flat, no, because you wanna have him elevated at least enough for the nebulizer to work. So semi-fowler, high fowler, so kind of this position or sitting up.
So I know these are scenarios, right?
Mhm.
But as respiratory therapists, do we have the autonomy to make those decisions? Should I not give them this? Or are we just following the orders? Or
We
should
know,
go-
you use your noodle, you can say, hey, doc, this patient's heart rate's 140 at rest with no distress, do you still want me to give him this albuterol? Well, let's check an EKG, they might get an EKG and try and figure out why the heart rate's that high, right? Or if, they have some kind of reaction that's not comfortable, you let the nurse know, you let the doctor know. So yeah, we do have autonomy. We could actually, based on our protocols, order medications or DC them based on circumstances too. So I can order devices, I can order all kinds of stuff based on protocol, so. Yeah, so you do want him setting up. He's actually in a decent position. So we got color, we got all of our vitals, we got cough. We checked to see if his heart rate went up by 20%. And how do you feel?
Better.
You feel better? Feel like breathing a little bit better? Okay, so you might feel a little jittery after all these treatments. I want you to know that's completely normal. Okay, albuterol can do that to you. If it gets uncomfortable, just let the nurse know. Okay, we can let the doc know, and maybe we can try and change it to something else or give you something. But it'll subside in about 20 minutes or so. Okay. Okay. All right. So you want to leave your patient safe and comfortable. Okay, which we did, and then you want to take the gloves off, and you want to foam out, and then you're going to document. Okay. Now I threw a lot of extra in there. Okay, because I'm kind of teaching you, but all you really have to do is go through the steps. All right. You guys have any questions?
Yeah.
Go ahead.
The dry powder and inhaler, they exhale like everything, and then they breathe in slow, just like fast.
Rapid with
Rapid.
these. For this one, it's slow. It's slow and steady, but a deep breath. It's not and deep. It's okay. So you don't want this to whistle. That's the difference. So depending on your device, so we have a little guy that we can actually take in the room, and we can do tests to see if they can do the flow rates required to do different devices. Okay, that's why I think at Atrium A, it's cheaper for the liquids, right? But anybody can do a nebulizer, right? Not everybody can do a meter dose inhaler or a dry powder inhaler. We get in there and they're elderly and they're weak and they don't follow commands because they got dementia and they can't take this, right? So then we got to convert it to a neb anyway. So I think that the atrium, in a way, it makes our work a little bit longer. Like it takes longer to get our therapies done because it's all liquid, but anybody can do it. So that you actually spend less time trying to convert things to this and that, less time away from the patient. You can actually get everything done, but it is a little bit more time consuming to just do everything liquid. Like you can see how fast these are. So these, but not everybody can do them. So, but this one with a spacer, as long as you can follow commands, right? Kids, we have different ones. We have some that have masks. So if you have like a little, like a baby, there's a baby size little mask that's on the end of it. I can go get one and show you. And then you just kind of put it on their face and let them breathe in and out normally on it, right? But, and then trying to get an infant to wear a mask to do a nebulizer, how do you think that goes? So you end up chasing them with the handheld, right? We actually block, it's called a blow by, and it's not as effective. But you end up blocking this off with like some plastic so that all of the neb comes out here, and then you're just chasing them with the nebulizer. And you'll see that a lot in peds. But a lot of if you run into someone like this young man here, you know, he's so used to, which is the sad part, is he's so used to getting a nebulizer, he'll just sit there and wear the mask like it's nothing. You know, and he knows that this is gonna help him. Instead of being afraid of it, he just sits there and wears it and, right, and does his thing. So it's sad, but it's also at the same time, you know that you're helping people. You know that you're helping them get better. And then the rest is like, how do we just get them managed when they're not in the hospital so that they don't end up back in the hospital? We want to get better quality of life. And today, there's a lot more medications and therapies available to try and help you treat your asthma, even than when we were kids.
I probably should go see a specialist, but I don't even go to the doctor. I hate going to the doctor now.
Why do you hate going to the doctor?
I did it so much in my life. I just don't want to do it anymore. I've been to the hospital hundreds of times with asthma, hundreds, hospitalized over and over. To now I just hate going.
Yeah, I don't blame you. But you know, you don't want to ignore the rest of your health either. You know, it's kind of like, think of it as preventative.
Yeah, I probably should go see a specialist, but
I can give you some recommendations if you want, based on where you live.
Good thing there's no doctors in healthcare.
Huh?
Good thing there's no doctors in healthcare.
No, I mean.
Yeah, I actually see the pulmonary intensivists at university. They're really good. I work with them every day, and they take care of me. They take care of me when I'm sick, and you know, I help them take care of patients when I'm well. So works out. Yeah.
For breathing with a nebulizer, they're just breathing normal through their mouths, but then every now and then
Yeah.
take a deep breath.
Yeah.
And hold it, or just
Yeah.
okay.
Just like you would with the MDI with the spacer or the dry powder inhaler. You always want to have them do a breath hold every so often, yeah, so that you get better, deeper deposition. And again, it's just to let the bigger particles kind of have time to rest onto the tissue. Like you're not just breathing in and out, back out. You want to let it give it time to deposit. So the breath holds are actually important.
They're breathing in through their mouth and out through their nose, or just
In through their mouth, out through their mouth.
Okay.
And then because COPD patients, you have to be careful with the amount of oxygen. Do you usually deliver it all on room air, or?
If they're on oxygen, you want to deliver it on oxygen, okay? And honestly, 10 minutes, 15 minutes on a nebulizer is probably not going to kill their drive to breathe. And to be honest with you also, I've only seen 2 to 3 patients in 20 years with severe COPD that actually had increased carbon dioxide with oxygen. It's actually really rare. Okay, but yeah, you can't give it on room air if they're on room air, but most of the hospitals don't even have room air because the issue that we run into is individuals that don't know end up putting them on room air instead of hooking them back up to the oxygen, and then we get called because, right, oh, my patient's desatting. You go in there, you find that they hooked them up to the wrong thing, or they're screwing the yellow caps onto the green, and they think that it's an oxygen flow meter. It's actually an air flow meter. It's happened a lot. So they've just basically eliminated in a lot of places the air flow meters, and you just have the oxygen, or a double flow meter, actually. So, okay. Any questions?
Are you usually the one diagnosing that they need these things? Or are you like usually coming in from someone else, like saying, oh, this person needs to better
Depends.
an inhaler and nebulizer?
It depends. So like they've come up from the ED, they probably already have orders. They'll usually have like bronchodilator protocol, or, you know, secretion clearance protocol or lung expansion therapy protocol. And then we go in and we talk to, what do you take at home? We look at their home meds, and then we order things based off of that, right? Or they might already have orders in. They might have been here for a week, but I still assess every time I see the patient to see if we can titrate things down, whether it's oxygen, do we need this device anymore, the secretion clearance device anymore? Do they need the albuterol every 4 hours? Can we decrease it to every 6 or to as needed now? So yes, we do make those decisions, and I've had them give me orders for something and I'm like, okay, well I need more. And especially in the emergency department, this didn't cut it, I wanna give them more. So they'll let you, go ahead, you know, so they can put in the order, or we can put in the order. It really kind of depends on the kind of autonomy you have with your physicians. And a lot of times that takes a little bit of work. They get to know you over time, depends. The ICU is a little bit different. In the ER, they're like, yeah, okay, go ahead. You know, they just want you to fix them. I've had docs walk out, what do you want me to do? I don't care what you do, just fix them, write the order. I've had docs look at me and do that. I'm like, okay, that's great. Just fix them. Okay, well this is what how about we talk about it, because this is what I think, just fix them. You know, so it just depends on the kind of relationship you have with your docs. I'm just kind of like, okay, just fix them. Well, this is what I want to do. Okay. And then I go back and I tell them what I did and whether it worked or not, you know. We work together as a team to make people better. And if you're not, like I said, if you're working somewhere and you have to call for every little thing, you're not practicing at the top of your license and you're not using your noodle like you should, that's not a place you want to work. You want, what I want is respiratory to assess is all I really want at my point in life. And then if it's something that I'm not comfortable with, or that I need, or I want the doctor to assess to see what his input is or her input is, I go to them. But we're the experts in our field too. This is all we do all day long is breathing. So you want to practice at the top of your license. You don't want to have to call to change the oxygen up by a liter. If you do, that's micromanagement, and how are you ever gonna really develop, right? But you gotta know your limitations, whether or not this is your scope, and whether or not this is the right thing to do, right? And that's why we have guidelines. That's why we have protocols. You can kind of follow them. They have this, and this going on, you do this. And then we don't have to call the doctor. So you want a protocol that you follow to guide new therapists to advancement, but not to stagnate an advanced therapist. Does that make sense? Yeah. So that's a good protocol. If they stagnate you and you gotta stop and you gotta call every 5 minutes, it's not a good protocol. But you do need to go, okay, well, I see this, call the nurse, I hear crackles back here. Do you think the patient needs some Lasix to get that fluid off? Because I know 4 hours from now, they're gonna be in trouble. Then now it's affecting their breathing, and now it's my problem, right? So it's all in your approach. Like, hey, what do you think? I hear some crackles back here. Do you think they might need some Lasix? What do you think we should do, right? And you just work together as a team to get the patient better. And sometimes, you get a little firm about things sometimes. But it is what it is. Ultimately, it's the doctor's decision what happens to a patient, even if it's frustrating. Okay, yeah. Any other questions? Okay. Guys, go ahead and practice.